right, well, good morning. I'll start get my screen on here. All right, can you see the screen? Okay, very good. All right, well, good morning. I am in the state of Wisconsin within the United States of America. It's a bright new day here for me at the time of 7:40 in the morning of March 20th. We are exiting winter right now and entering spring. Last Monday, we had 3 to 4 inches of snow, and the forecast today is sunny with a high of 55 degrees Fahrenheit. My name is Dr. Cheryl Loken. I have a special interest in geriatric feline medicine, and I'm excited to share with you today on the topic of chronic kidney disease in the cat. As we go through the presentation, I recommend that you write down any questions that you have, and I will be happy to address what I can at the end of the presentation. The PowerPoint slides will be made available to you on the VetNet website foundation. Okay, so chronic kidney disease. This is a fairly common condition seen in older cats, so you might be seeing a patient specifically for an owner concern, or you may be looking for this in any cat that is 10 years of age or older during a regular annual exam. So today we're going to be looking at the history, what an owner will typically notice, or questions that you will want to ask during a geriatric feline annual exam. We'll look at the physical exam, specific things to look for in the different organ systems that may signal chronic kidney disease or one of the other differential diagnoses. We'll look at the differential diagnosis, the most common diseases that can have similar presenting concerns and histories. We'll look at key diagnostics that are used to confirm chronic kidney disease and exclude other diseases, and also to help us stage the progression of the chronic kidney disease and the corresponding prognoses. We will look at that staging, what determines the stage and a substage of chronic kidney disease, and the particular values within each stage and substage, and how that relates to prognosis. And then we'll look at treatments, what treatments are available depending on the stage or substage of chronic kidney disease and the preferred order of those treatments, and then end up with monitoring on these patients. So we'll start with history. This can be a concern brought up, again, by the owner, or something that you will want to be asking the owner on any cat that you're examining that is 10 years of age or older. The 3 main concerns brought up by an owner are increased thirst, increased urination, and gradual weight loss. So with polydipsia, the increased drinking, this is not always observed by the owner, as cats are not typically big water drinkers, and their drinking behavior is not always seen or monitored. But they may see the cat drinking in unusual places, such as the sink or bathtub, toilet, or even a bird bath. As you can see, the background slide of this presentation is actually one of my previous cats that had chronic kidney disease, and she liked to drink out of the bird bath that was on our deck. Owners may be having to fill the water dish more frequently. This can be difficult to determine in multi-cat households or cats that go outside. The next most common thing you'll see on the history is polyuria, or increased amounts of urine. So a lot of times the owners will find larger amounts of urine in the litter box, or having to clean the litter box more often. Or the cat may be urinating in inappropriate places. This may be because of the polyuria or because of a urinary tract infection secondary to the more dilute urine that is found within chronic kidney disease. And again, that can be difficult to pinpoint to one cat or another if cats go outside, or if this is a multi-cat household. We're also going to be seeing gradual weight loss in these animals. Other things that you can be seeing that are probably more with advanced disease are lethargy. The owner may be concerned that the cat is sleeping more or is hiding, which can be seen with azotemia or anemia. They may become anorexic or hyporexic. This is usually with the uremia. Vomiting, again with uremia. Constipation can be a sign of dehydration due to the inability of the kidneys to concentrate the urine. And they might even be seeing acute blindness. It may be the only thing that the owner sees. That can happen in early or late stages and is caused from being secondary to hypertension and having that retina detach. If caught early and treated appropriately, this can potentially be reversed and save some vision. In the physical exam, in the early stages of the disease, your physical exam most likely will be normal. In later stages, you can see such things as a poor hair coat due to decreased grooming, either with oral disease or that they're just not feeling well from the azotemia. A thin body condition score, overall loss in body condition, and also muscle wasting. You can see dehydration as seen by tacky mucous membranes and prolonged skin tint, and also firm feces felt in the colon. Oral disease is a problem in these cats. You can see, first of all, pale pink membranes if the cat is anemic, or gingivitis, periodontal disease, and halitosis from dehydration and uremia. During the thoracic auscultation, you can possibly hear a heart murmur if they are anemic. And during abdominal palpation, you may feel small, irregularly shaped kidneys. And again, looking back at that eye, you may see a retinal detachment or at least tortuous retinal vessels from hypertension secondary to chronic kidney disease. Or the other most common cause for hypertension in older cats is hyperthyroidism. So you want to make sure to make it a part of every exam on older cats to do a retinal exam. I prefer using the indirect method with a 20 diopter lens, but you can certainly use your ophthalmoscope too and do direct ophthalmoscopy. When you're looking in the eye, you can also just sometimes shine a light in there, and if the retina is fully detached, you'll actually just see like this membrane floating around in there like a parachute. Differential diagnosis. This is certainly not an exhaustive list. I've just listed the probably the most three common that I see, which are diabetes mellitus, which certainly does cause polyuria, polydipsia, weight loss, and lethargy and vomiting. Hyperthyroidism is a very common disease that we see in older cats and can cause weight loss, vomiting, or acute blindness from hypertension. And also this disease can be hiding underlying chronic kidney disease. And when the cat becomes regulated for hyperthyroidism, then you actually might start seeing the signs of chronic kidney disease and will need to treat it at that time. And then obviously neoplasia of any kind can cause weight loss, but small cell intestinal lymphoma is also frequently seen with weight loss and the vomiting and or diarrhea. All right, some diagnostics that we're going to want to run. First and foremost is getting a urine sample, preferably by cystocentesis, to avoid genital and extragenital contamination. And the key to chronic kidney disease, to diagnosing that, is a lower specific gravity that's going to be under 1.035. If you see that and the chronic kidney disease is diagnosed if the serum renal values are increased, If those serum renal values are normal with a lower specific gravity, I will oftentimes have the owner withhold water overnight and recheck that specific gravity to see if that comes up, because obviously that specific gravity can be lower if the cat just happened to be drinking. Although in my clinical experience, the majority of cats with normal kidney function have a urine specific gravity over that 1.035 at any given time. And knowing that when over 2/3 of the functional renal mass is lost before the kidneys lose their ability to concentrate urine, and actual isocynuria, where the kidney has no concentrating ability, is between 1.008 and 1.012. Within the urine, you may see proteinuria, and in these cats that are diagnosed with chronic kidney disease, you always want to check a urine protein creatinine ratio. For the UPC to be diagnostic, the urine sediment must be inactive, because the presence of red blood cells and white blood cells will falsely elevate this value. You don't want to trust the urinalysis test strips for this, because they can give you false results. You need to look at the sediment under the microscope. And you can also see urinary tract infection in these cats more frequently, because with the more dilute urine, they are just more susceptible, and especially in female cats that have a shorter urethra and having that within a closer proximity to the anus. On a CBC or complete blood count, about the major thing there that you may see later in disease is anemia due to insufficient renal erythropoietin production. And normally this would be a normocytic, normochromic, and poorly regenerative anemia that you will see. The chemistry panel, azotemia, which is defined as an increased blood urea, nitrogen, and creatinine. Creatinine is the more reliable marker for kidney function, or indirect marker for the glomerular filtration rate, but it isn't increased until 75% of the kidney function is lost. The daily production rate of creatinine depends on muscle mass, which may be of clinical importance in these older cats with age-related muscle wasting, or when the muscle mass gradually declines from chronic kidney disease progression. The BUN can be influenced by extrarenal factors, such as intestinal protein content and liver function. The symmetric dimethylarginine, the SDMA, is a newer test available that can be increased with as little as 25% loss of kidney function. Other things we're going to see on that chemistry panel may be a decreased potassium, because the kidney is the main site for potassium regulation. We could also see increased phosphorus from renal secondary hyperparathyroidism, and that in itself is a negative prognostic indicator. Decreased calcium can be seen as an increase in the phosphorus causes a decrease in calcium, which signals the body to draw more calcium out of the bones. And you can see a decreased bicarbonate or acidosis. The metabolic acidosis causes a breakdown of muscle, which contributes to the buildup of toxins and further lowers the level of potassium. And we always want to look at that total T4. In chronic kidney disease alone, that would be normal. But if increased, as in hyperthyroidism, that can be masking underlying renal disease. And in these cats, you want to be taking a blood pressure. Specifically, we're looking at the systolic blood pressure, because again, in chronic kidney disease and hyperthyroidism, those are the two most frequent diseases seen with hypertension. Big key to this is that it must be performed in a quiet, controlled environment. So you want to have like a dark room, allow time for the cat to become adjusted to that room. You may want to spray a towel with a feline pheromone to help the cat get calm, and therefore you'll get more accurate readings. You want to weigh the advantages or disadvantages of having the client in the room. Is the client a nervous person from which the cat will also get worked up? Is the client loud and talkative? I typically don't have the client in the room. If I think I am getting falsely elevated readings without the client, then I may have the client come in and hold the cat in his or her lap and explain that we will all be calm and quiet. You can have calm, soft music playing in the background. And remember that this is a two-person job. One person to gently hold the cat. Remember that also that cats can sense apprehension, so you must be calm. Breathe slowly, talk quietly if you must talk at all. And the other person is performing the measurements and recording the results. Now there are two types to get an indirect blood pressure, Doppler versus oscillometric. The Doppler method is probably more accurate, but does require a little more restraint of the cat. And you should be using headphones to avoid stress hypertension from the sounds that the Doppler machine makes. The oscillometric method is a little less accurate, but it doesn't require quite as much restraint. So both can be used. Just use what you have as tight as possible. Have the blood pressure off at the level of the heart, and make sure you get maybe more if the cat in his or her level of comfort and alertness, and then average those readings out. And make sure you are reading the cat in its behavior. Is the cat relaxed, or is it struggling and fearful? You can always give the cat more time to relax in a quiet place for several minutes and then try again, or even on a different day. Whatever you end up doing on an individual cat, make sure you're recording that so you can repeat that each time the cat is in for a blood pressure recheck. For example, I will put in a patient's record that we placed him in a darkened room on a towel sprayed with Feliway, which is our feline pheromone that we use here in the United States. Allowed him to hide his head in my arm while rubbing behind his ears, and used cuff number 2 on the left front leg. Okay, so staging. This chart was created by the International Renal Interest Society, and I have put up here a website where you can look at that and get more information on the staging. So the staging is based on the creatinine. Here I have it listed in the milligram per deciliter, and that SDMA in microgram per deciliter. Stage 1 is where the creatinine is under 1.6 and the SDMA is under 18. So it's a normal creatinine and normal to mildly increased SDMA. But you may have other abnormalities such as decreased urine-specific gravity or proteinuria, abnormal imaging if you've taken any x-rays or ultrasound and see some abnormalities within the kidneys, or you're feeling those small irregular kidneys. So the creatinine may be in the normal range on these for any particular lab, but with the insensitivity of creatinine as a screening test means that cats with values close to the upper limit may often have chronic kidney disease. So you want to look at the whole picture here, not just one value, but all of these values and your physical exam as well. That's why your physical exam and your history are so very important. In stage 2, your creatinine is going to be between 1.6 and 2.8, and your SDMA between 18 and 25. Stage 3, creatinine is going up to 2.9 to 5, and SDMA to 26 to 38. In stage 4, your creatinine goes over 5, SDMA is anything over 38, and you're obviously here seeing increased clinical signs and a risk of a uremic crisis. So within each of these 4 stages, you will also have a substaging by proteinuria and by blood pressure. And the first one, the UPC under 0.2 is non-proteinuric. 0.2 to 0.4 is going to be borderline, and over 0.4 is going to be proteinuric, and these are ones that you will be treating. Again, substaging by blood pressure, anything under 140 for a systolic blood pressure is normal. 140 to 159 is pre-hypertensive, so we're not treating these, but we're maybe monitoring them more frequently. And between 160 and 179 is hypertensive. These are patients we need to treat, and anything over 180 is severely hypertensive. All right, so once we have a diagnosis of chronic kidney disease, it can't be reversed. So the goal is to slow the progression of the disease. It is important to discuss this with the owner, as it does involve repeat testing and may include several different medications. So my goals for treatment: when I first start seeing a urine-specific gravity under that 1.035, or that alone, or if it's combined with an SDMA over 14 or creatinine over 1.6, I start a renal-friendly diet. These diets are restricted in protein, phosphorus, and sodium. They're supplemented with potassium because, again, a lot of times that potassium will start falling in these cats. It's also supplemented with omega-3 fatty acids, B vitamins, and fats. Of all treatments, dietary modification has the most positive long-term effect on outcome. Introducing a new food earlier in the disease can also help increase acceptance. Sometimes later in the disease, when a cat isn't feeling well, it's actually harder to make this good dietary change. When the UPC is over 0.4, then I start adding benazepril. The dose is given here at 0.5 to 1 milligram per kilogram. For a typical sized cat, that's going to be 1/2 of a 5 milligram tablet given once a day in an average sized cat. This is a vasodilator, so it may also have an effect on the systolic blood pressure. So you want to maybe even get this done first before leaning toward your amlodipine under the next one here under systolic blood pressure. If it's over 160, I start treating with amlodipine at 0.18 milligram per kilogram, which is a quarter of a 2.5 milligram tablet given once a day. And then I make sure that I'm rechecking that blood pressure in a week using the same procedure each time. For dehydration, or which may be seen by constipation or tacky mucous membranes or prolonged skin tent, you want to make sure that the owner understands that this cat needs to drink more. It can't concentrate the urine, so it does have an obligatory polydipsia. So they have to have a constant fresh water supply. They can try to increase the cat's drinking by offering a water fountain or a dripping faucet even, giving canned food that would have more moisture in it, making sure the bowl is full to the top, or even maybe getting a bowl that has a larger mouth to it, so as some cats don't like its whiskers touching the sides of the bowl. Making sure that the water dish is in a quiet area, or ideally multiple areas, and away from noisy appliances. You can give subcutaneous fluids, giving up to 100 milliliter per cat per day, and I usually divide this over 4 areas. You may only need to supplement fluids once or twice a week, or it may be every day, depending on the stage of the chronic kidney disease. And owners can do this, so teach them to. They can monitor the mucous membrane moistness, skin tent. You do have to be a little more careful with the skin tent in older cats, as sometimes Just the elasticity of their skin does decrease over time. If a cat is becoming constipated, that is a sign of dehydration, or sometimes their appetite can drop off. All of these things the owner can be monitoring. And then you can also give psyllium husk and probiotics to help with constipation as well. Anorexia or even hyporexia with a decreased appetite. Mirtazapine is a wonderful appetite stimulant. The dose here is 1.88 milligrams. This comes in oral and transdermal forms. So for the oral tablet, it's actually 1/4 of a 7.5 milligram tablet every 1 to 2 days as needed. And if you need to, in a very anorexic cat, you can place an esophagostomy tube. This is a relatively easy procedure to do. And then you're also able to give extra fluids and medications by the tube, and it can be kept in several weeks or even months if needed. For vomiting, merobitant is a wonderful antiemetic. I use that at 2.5 milligram per kilogram once a day. You can use this up to 5 days, and then it is recommended that you give a 2-day break or washout period for that. For hyperphosphatemia, number one thing, again, is going to be that renal-friendly diet. That is usually all that's needed in those first 3 stages of chronic kidney disease. Phosphate binding agents, unknown added benefit, but can be used in that stage 4 after being on the renal-friendly diet for at least 4 weeks and rechecking to see where that value is at. And if it's still elevated, then certainly use those phosphate binders to try to bring that down. Hypokalemia. First thing, again, that renal-friendly diet. If that's not enough, then there are a couple of different options here to increase the potassium. You can give potassium gluconate at 2 to 6 milliequivalents per cat per day, divided every 8 to 12 hours, or potassium citrate at 40 to 60 milligram per kilogram per day, divided every 8 to 12 hours. This has a potential benefit of alkalinization. And looking at alkalinization brings us to our next area here of treatment, which would be with metabolic acidosis. First thing, again, is that renal-friendly diet. Always do this first and then recheck values later after they've been on the diet. The potassium citrate, which again was given for hypokalemia, can also help take care of the metabolic acidosis. Or you can use sodium bicarbonate. This is not palatable, but it's easy for you to be able to mix up and give if you can get the cat to take this. So there's just a little recipe here, a homemade recipe. You can actually add 17 teaspoons of baking soda to 1 liter of water, and that gives you a 1 milliequivalent solution per milliliter. And you'll give 1 to 2 milliliters of this once a day or twice a day, depending on the severity of the acidosis. And the solution is stable up to 3 months if capped and refrigerated. Cats with anemia, the goal is when the hematocrit is under 22% to start treating at this time. There is a recombinant human erythropoietin called darbepoetin. It is very expensive and it can cause antibody development within the cat because it is not from the cat. This is usually quite late in the disease, and with the cost and potential for adverse reactions and unfavorable prognosis at this point, euthanasia must be considered. So I have actually not had a client that would pursue this treatment. All right, looking at monitoring. Once this patient is stabilized, you want to monitor every 3 to 6 months, depending on the stage of chronic kidney disease. So a cat that only has a decreased urine-specific gravity or mildly increased SDMA with no proteinuria and is normotensive, putting it in a stage 1, that is non-proteinuric and normotensive, would be fine for just rechecking every 6 months. Obviously, a cat that is in a higher stage of chronic kidney disease with proteinuria and or hypertension should be monitored every 3 months. This will also be between you as the veterinarian and the owner according to his or her finances and goals. During every visit, you should include a full physical exam, checking the weight, the hydration of the cat, and performing oral and retinal exams. You'll also want to be looking at doing that CBC, chem panel, and T4. Continue to monitor those renal parameters, but also looking for any secondary infections or developing hyperthyroidism. A urinalysis with a UPC and culture as needed, especially if the cat has an acute uremic incident. Be looking for underlying causes. And one of those is like a urinary tract infection or systemic infection. That's why we're also looking at that CBC. Blood pressure. You'll need to be done more frequently in cats that have been proven to be hypertensive. And then I always like to chart this out for the owners. They are a partner with you in this, so make them an active partner. Help them to understand what we're looking for and how these different treatments are working together. So I have a handout for owners that lists the blood tests, urine tests, and other tests that I'm especially careful to monitor for in chronic kidney disease. It explains a little bit about each test and what I'm looking for as the disease progresses. So this is the little handout that I have developed to hand out to my clients that have kidneys or cats with chronic kidney disease. So again, it's looking at those different blood tests, explaining what the BUN is, the creatinine, the SDMA, the electrolytes, how they are regulated by the kidneys and whether they end up being increased or decreased, and a bicarbonate, the hematocrit within that CBC, the different urine tests, looking at the specific gravity and explaining to them how far along kidney disease actually is before this happens, when they start losing their ability to concentrate urine. That UPC and why they would be needing the benazepril if the UPC is elevated. Looking at urine white blood cell counts and or cultures, again, because as the concentrating ability decreases, that urine becomes more dilute and is more susceptible to urinary tract infections. And if they have urinary tract infections, that can make it harder for them to be regulated. Other tests that we're doing, the physical exam, weight and systolic blood pressure, and also getting feedback from the owners as to how they feel that the cat is doing. All right, here I have included a chart on a specific cat that I had worked on. So this is from Chubby. He was a neutered male domestic short-hair cat. This was at a time when the SDMA was not available, so that's not included. I have since made a new version of this, and it does have the SDMA in it for cats that I'm working with now. So Chubby's estimated birth date is November of 2003. He was first seen at our clinic in November of 2005. He was found as a stray by his current owner, and he was already full grown. And he was full grown, weighing 10 pounds. He had previously been neutered and had moderate dental calculus. So he actually could have been older. So this is probably a low estimate. Normal blood work was performed on Chubby in August of 2014. at that time he weighed 10 pounds. In May of 2015, again, that's not even on this chart yet, but in May, the owner thought Chubby was losing some weight, and he was down to 9.4 pounds at that time. But the owner needed to move and was looking to rehome Chubby and decline blood work at that time. So then we didn't see Chubby again until August, and that's his first date on his chart here, when his new owner had noticed polyuria and polydipsia and brought Chubby into the clinic for a full workup. So you can see that Chubby had lost 1.3 pounds from his last normal blood work and exam 1 year earlier. Both his BUN and creatinine were increased, and his urine-specific gravity was just out of the isoscenaric range at 1.016. His UPC was fine, and he had hypertension. Chubby has chronic kidney disease. He is in stage 2, non-proteinuric hypertensive. So Chubby was immediately placed on a renal-friendly diet. What we have here is called prescription diet KD, so that's why in the treatments it says that PD for prescription diet K/D. And then we started him on amlodipine at 0.625 milligrams once a day. So that's that initial starting dose of 1/4 of a 2.5 milligram tablet. His blood pressure was rechecked and found to be in the normal tensive range. So his new classification at this point would be stage 2, non-proteinuric, non-hypertensive, and in parentheses I'd put treating, because we're treating hypertension and it is being managed well. At his next recheck, he is hypertensive again. So his dose was doubled, and again that resolved his hypertension. 1 year later, in August of 2016, his systolic blood pressure moves into the pre-hypertensive range, his value at 145, and pre-hypertensive range is from 140 to 159. No changes made in his medication at this time. Is that still okay? In 2017, no changes were needed as there was no progression of his disease or clinical signs. He had a very good year that year. In March of 2018, he was started on a joint supplement and pain medication to help with some arthritis that he had. He was developing dry stools, and he needed to start getting some sub-Q fluids, which his owner gave him on an as-needed basis. So she would monitor the dryness of his stool and also his appetite. Sometimes if he just wasn't eating as well, she would give him some sub-Q fluids, and that would help him. In July of 2018, his potassium was low. So we actually did start him on some potassium citrate granules, which unfortunately did not get noted in his chart here. But he responded nicely to that. And the following value that was taken in January of 2019, his potassium is back in the normal range. Also not included in this chart was the fact that in September of 2018, Chubby did start struggling with some episodes of decreased appetite and vomiting. So he was placed on mirtazapine and meropitant off and on as needed. The final date on the chart is supposed to read March of 2019, not 18. This was just a short recheck of his BUN and creatinine because his overall condition was declining, and the owner was looking for more answers as to whether it was time for Chubby to be euthanized or not. Chubby was euthanized on March 31st of 2019 at the age of at least 15 and a half. He actually may have been more. And it was for his problems with arthritis and weakness. He had remained in stage 2, non-proteinuric, pre-hypertensive with treatment, chronic kidney disease, and was well maintained for 3.5 years. So that is the end of my presentation. I would ask now what your questions are. So if you have any questions, you can go ahead and put them in the chat box, or if you feel comfortable, you can unmute yourself and give me your question on chronic kidney disease in the cat.
Yes, this is a time for us to respond, and I'm sure that all of you having something to ask to Dr. Cheryl.
Good evening, madam. Good evening.
Hello there.
Good evening, ma'am. Hello.
Yeah,
Hello.
carry on. Yeah, we can hear you. Carry on, doctor.
Does mirtazapine and meropenem does available in India, ma'am?
I'm hearing mirtazapine and meropenem. I'm not sure on the question about those drugs.
Does it available in India?
Oh, available in India.
Is it available in India?
That I guess I don't know. I would have to ask Dr. Dixon on that, but I know that certainly through the internet, that should be available through different companies. That is the actual drug name, not from any specific manufacturer name. Do you know, Dr. Dixon, are those available in India?
Yeah, I need to check that.
Okay.
I don't know, but I need to check that.
Sure.
Anybody wants to ask any questions, you're most welcome to ask. Or put in the chat box if you don't want to. Dr. Jaypal? Okay, that's one question is there already.
Okay, I do see a question in the chat box. What is the occurrence of diabetes with chronic kidney disease? I actually have not seen those together. I'm sure it can happen, but I personally have not seen that. So I would say that that is a low occurrence. But in contrast to that, hyperthyroidism, we do see that with chronic kidney disease. Okay, another question in the chat box. Can you explain the role of fluid therapy in chronic kidney disease? Certainly, I've explained a little bit with the subcutaneous fluids that owners can give on a maintenance basis. There could also be times when a cat seems to be regulated fine, and then they would have a uremic crisis where all of a sudden their kidney values go quite high, they stop eating and start vomiting. Then that is actually a time when we can keep them in the clinic and give IV fluids for a day or two to try to help flush those kidneys out and resolve that acute uremic crisis. So any other questions? I think using the chat box works very well. I am hearing just a little bit of background noises in other areas, so that might work best to use the chat box.
Or you can unmute yourself and you can speak, but otherwise just keep it muted. There's one question is there. There are questions are there in the chat box.
Okay, there is a question in there. Any need to treat secondary hyperparathyroidism or parathyroiditis? Normally, when you've already done done these things, the hyperparathyroidism can cause some problems with like the calcium and phosphorus regulation. Usually if you're treating with the things that I've outlined here, that takes care of all of that. And there is in the chat box, Dr. Benjamin has given us a supplier for meropitant. Okay, another question in the chat box. Are phosphate binders effective in hyperphosphatemia? They can be. Again, the first thing is the renal-friendly diet, because that is our biggest help. I would certainly try phosphate binders past that. It's just not as guaranteed that you'll get a good result, but certainly worth trying after the diet. The diet needs to be the first thing, and for a good 4 weeks, get them on that diet for 4 weeks, then recheck to see what the phosphate is. If it is still elevated, give those phosphate binders a try. What are the common fluids used in chronic kidney disease? Normasol, lactated ringers, normal saline can be a lactated ringer solution is probably the best. And Dr. Benjamin also has in the chat box another place that you can get mirtazapine from. So both meropitant and mirtazapine are available to you there. Thank you, Dr. Benjamin, for looking those up. They're wonderful, wonderful drugs and help our kiddies very much. Okay, what can you do for blindness? Again, if it is caused by hypertension from chronic kidney disease, if it's caught very early, get them on that amlodipine right away. If you've caught it early and you get them on that amlodipine, sometimes that retina can reattach and they can regain vision. If it's later in the disease, or if the retinal detachment is older, again, you still need to get them on the amlodipine to treat the hypertension, but they may be permanently blind. And blind cats can still do very good in their home territory where they kind of know the environment. And then you just treat them like any other chronic kidney disease cat. It's just that they are blind and at that point would not regain sight. But you still need to keep that blood pressure under control, because the other big target for target organ damage would be the heart, eyes and heart.
Dr. Cheryl?
Yes.
Can you hear me?
Yes, I can.
Do you mind in throwing some light on digestive tract, digestive system in enteritis, and what are the common drugs, the astringents you can use in the diarrhea of the cats, and as well the parental drugs, and also can ivermectin used in the cats, the injection of ivermectin?
Okay. For today's session, we're keeping questions strictly to chronic kidney disease, but it is interesting that you should ask about diseases of the stomach and intestine, because Dr. Dixon has asked me to do another seminar, and that's going to be in May on stomach and intestinal problems within the cat, and I could address that at that time.
Okay, thank you.
You bet. Another question, any suggestions for hypothermia in chronic kidney disease? Big areas for this would be, cats love a sunny perch for them. So certainly having areas like that, or warmed blankets, or even warmed water bottles, or you can actually take a bag and put rice in it and put that in the microwave to heat up, and that will have a nice warm area for the cats.
I think we have come to the end of the session. I mean, any more questions, sir? Quickly you can ask, otherwise we're going to finish it. And before finishing, I would like to request you to, oh, there's a question, is there? Yeah, there's a question, is there?
Okay. Okay, there are a couple of other questions here. What is the importance of the protein creatinine ratio? The importance, that determines how much protein is being spilled out through the kidneys. And that is also, it continues to harm the kidneys. So the progression of the chronic kidney disease will go much faster. And it also is a negative prognostic indicator for us. So that cats that are losing protein through their kidneys do have a lower prognosis for long-term survival. But there is treatment for that, and that was the benazepril, which works as a very good treatment for that. Painkiller usage in chronic kidney disease. Our example today was Chubby, and he did have some arthritis pain. So I had used gabapentin in him. We need to be very careful with our non-steroidal anti-inflammatory drugs, because they can, again, worsen kidney disease. So that's why I chose gabapentin. What is the first diagnostic test we should go for chronic kidney disease? The first one I choose is a urinalysis. And I like to get that by cystocentesis. That is a very easy procedure to do in a cat. And most times the cats will have urine in their bladder. Because I'm looking at that urine specific gravity first and foremost. But again, we like to get a big picture. That's why we are doing all these other things too, the CBC, chemistry, a blood pressure. Is there any drug available for reducing the creatinine? There is not a drug specific for creatinine. Biggest thing is, again, that renal friendly diet. And part of that is a lower protein, because creatinine can be elevated due to the higher breakdown of proteins. Within the United States, one of the foods that we use here is called Prescription Diet KD. They actually have two different forms. One is their regular KD, which is more protein restricted. They also have one called early renal support, and that's less protein restricted, which I like to use more early on when cats are just first diagnosed and they don't have such high BUN and creatinine levels. Once those levels start creeping up, then I will go to a more protein restricted diet. Blood pH in chronic kidney disease. That has to go along with the acidosis. That's why, number one, we're getting the cat on the renal friendly diet and using like the potassium citrate or the baking soda formula there. Otherwise, I'm not typically doing a blood pH on every check. I'm looking more at that bicarbonate value.
Okay, thank you so much for participants. Made these programs more interactive. You asked a lot of questions, really appreciated. And before we close, I'd like to ask you to maybe you switch on your video so that we can take a picture with Dr. Cheryl. And before we say goodbye to her, and she will be coming back again. She said that she will be here on May 1st. So, yeah, some more people. Yeah, good. Some more people. Maybe some more people can switch on the video so we can take a picture. Still, you are most welcome to put questions. We are not stopping like that, but we want to take a picture before we say bye to her. I mean, she will be coming again in 1st of May, and you can go to website, you can register for yourself to know more about cats. And she will be doing digestive system in the second webinar. I think people are not there.
Okay. Good.
Some more people have come, I suppose. Okay, thank you, Dr. Cheryl, for taking efforts to prepare this presentation and make it more very simple and with lot of practical tips. So you talked from your...
Hello, sir. Sir, only one question, sir. Sir.
Please, Dr. Jayapal, please carry on.
Sir, actually, it's to Cheryl, sir. I'm Dr. Jayapal. Actually, in the serobiochemical test, the amount of serum and creatinine, in what level we can say the prognosis it can be guarded or otherwise it's a prognosis not guarded. In what level we can say to the client?
Am I here? If I'm hearing correctly, I'm hearing kind of the level of like BUN and creatinine as far as prognosis.
Yes.
Yes. Okay. When that creatinine is reaching 5, the prognosis goes much lower, or anything over that, especially when the other parameters are also, when you also have a high BUN, your SDMA is also elevated and your phosphorus is also elevated, then the prognosis becomes very poor. Lower.
Thank you.
Yeah, you bet. Thank you.
Okay, thank you, participants, for staying till the end. I saw so many people in the beginning. I saw people from Indonesia and Malaysia and Sri Lanka and so many states from India. I really thank all of you for sparing your time. And then if there's any more question you can ask, or otherwise we're going to finish it. And we really appreciate that your patience to to stay there for 1 hour. And we are looking forward to serving you with more knowledge. And next Saturday, 6 o'clock, we'll be having another speaker with the next topic. Kindly go to the website and register yourself, and you'll get the link. And we want to empower you with the skills and expertise so that you will be a great blessing for people who are living around you. So thank you so much for giving your time.
Happy Jayapal.
So thank you, Dr. Cheryl. Okay, this only.
Welcome, Jayapal.
Thanks.
You're welcome.
Yeah. Good. We want to say
thank you, ma'am.
You're welcome. Thank you for being here today.
Yes.
Thank you, madam.
Yeah, thank you, Dr. Victor's also here joined. That's great, from Andhra Pradesh. That's really good to see him also. And people from Kerala.
Thank you, sir.
So many states are there.
Thank you very much.
Yeah, good to see all of you, and stay till the end. That was really good. Amazing. Thank you. Bye-bye. Good night.
Goodbye, everyone.